There we go. All right. Hi, everyone. Looks like we have early bird, already 100 people. While you're waiting for us to get started, we'll get started right at 12. If you want to chat in the names of the other people who are in the room with you and their credentials, so whether or not they are an RN or an MA, we'd really appreciate that. And we'll get started right at 12. And yes, Liz, we want all the names in there. I think that you can only see the, there we go. I'm seeing lots of familiar names, Macrina. I think we have repeaters. Oh, you're muted still, Macrina.
Can you hear me now?
Now we hear you.
Okay.
All right, welcome everybody. We're gonna get started right at 12. And while you're on, if you could please just chat in the names of the other folks who are in the room with you and their credentials too, so that we can make sure we count who all's joining us. Alyssa is saying, just me and the dogs. So, you know, we were supposed to be doing this, Macrina and I were supposed to be together, and what went out?
The water went out first and then the air conditioning.
Yeah, the water and the air conditioning went out. So we're also here with our dogs, or I'm with my dog. Macrina's with cats.
I have 2 cats.
Yeah. So hopefully we don't get too much barking. Oh, wow. I think we're getting lots of representatives from all over the state today who are chatting in their names. Apache County, it is close to 4th of July. So all of you who've ever been to the Sholo training know that I'm heading up to Big Lake because that's where we go camping around 4th of July. So I'll wave at the health department on my way. And folks calling in from Yuma, the only place that is as hot as or hotter than Phoenix this time of year is Yuma. So we are kindred spirits with you. So I think we'll go ahead and get started. My name is Rebecca Nevadale.
And I'm Macrina Leach.
And we are your on-camera tips trainers today. And if you were here last time, you heard us shouting lots of names. Blanca, do this. Chris, do that. So there's a whole team of folks that are working behind the scenes to be able to provide you with the tips trainings this summer. And we're lucky today to have our executive director, Debbie McCune Davis, with us. So Debbie, do you want to give everybody a welcome and kick us off?
Oh, I'd love to. Thank you, Rebecca. And thank you, Macrina. You guys, so impressed with the program you put together today. Good afternoon, everybody. I am the Executive Director of TAPI, and I just want you to know that we appreciate your being with us today. This is our second summer tips training, and our trainings are designed to bring you the most up-to-date information so you can manage your immunization practice to the very best skill level that you can. Today, they're covering 3 topics: vaccine basics, understanding advisory committee, on immunization practices and their recommended schedule. And you're going to see a demonstration of the Arizona Immunization Information System and how it's used for patient recall. Each of these topics will help you build or refresh your knowledge and give you more confidence in delivering vaccines to your patients. I want to remind you that all of our strategies are built on effective communication. We do our best to provide good information to you. You offer well-informed information to your patients, and then we learn from your experience. So it's really important that as part of these trainings, you ask questions, you share your challenges, and you engage freely in the conversations that we have with you so we can all learn together. And it is together that we will do the very best we can to keep Arizona safe, healthy, well immunized, and meet the impossible challenges that we're being presented with in a COVID-19 environment. So happy you're with us. Thank you.
Thank you, Debbie. And we are, you know, Macrina and I have both been members of TAPI for a long time. And this truly, the tip sessions is truly one of our greatest impacts on the community, because we get to help answer some of your questions so that you can educate your patients and so that you can implement best immunization practices. So every day when you go to work, you're literally saving lives. And we think that a lot of times you forget that and you miss out on really honoring that part about your job, that when it's 9 a.m. and your doc is already running 30 minutes behind, and you go into the exam room and there's Mrs. Smith with all 4 of her kids, and you know she only has an appointment for one of those kids, and you do everything that you have to do as quickly, as efficiently as you can. And then as your hand's on that knob and you're trying to walk out the door, she says, I have some questions before the doctor comes. You take a breath and you answer her questions. And by doing that, you empower her to bring up her concerns to her provider so that she can make the best decision for her family and for her kids. So that by the time you're back in that office with the immunization to administer only to the child with a scheduled appointment, you are preventing these diseases. You are making sure that that patient does not get these diseases. And it's not just about that patient, right, Macrina?
You know, it's not. When you immunize that kiddo, you're also protecting all those folks around them, the grandparents, the family, the friends, the uncle who may be receiving cancer treatment. We've actually seen rates of pneumococcal and Haemophilus disease drop in our older population because you're immunizing all those kiddos. So, geez, you guys touch many more lives and protect many more people than just those kiddos you see every day.
Yeah, it really is one of the best parts, I think, of our jobs is to be able to thank you for that. And thank you for keeping our community safe. So we wish that we were in person, and we know, you know, we're not this year. So, but we do want to thank the Arizona Telemedicine Program and the HRSA funded Southwest Telehealth Resource Center for letting us provide this training virtually. And we're really thrilled that we have been able to reach a lot more people than we have at previous tip sessions, because you're all signing on the other MAs who don't get to come. And if you haven't done so already, please go ahead and chat in the names and the credentials of the other people who are in the room with you so that we know who all is joining us. And you're going to want to get used to the chat box, because we are trying to keep these tips trainings that are now virtual as interactive as possible, as conversational as possible, and just kind of the same tone that you're used to for those of you who've been to our tips trainings before. So throughout the training, chat in your questions, chat in your comments, participate in the polls, and let's just, you know, make the most of this physically distant. And for Macrina and I, we're even more physically distant than we wanted to be. Normally we do these trainings together. This is our first time doing it from our own homes because the air conditioning went out in the building we were supposed to be in. So, so bear with us if we're a little less polished. This is the first time we're doing it. So we have a couple. Last time we met 2 weeks ago, we talked about diseases, we talked about herd immunity, and we talked a little bit about COVID-19. And on the right side of this slide here, you'll see the question that we asked in the evaluation about should we spend some time giving brief updates about COVID-19? And most of you said yes, that is valuable time spent. We're going to try to keep that to about 10 minutes today, abbreviate it just a little bit, and we're changing how we do that a little bit. The other thing that's changed for this week is that we're going to keep this line open for 15 minutes after the training is finished, just to try and get more of those vaccine related questions answered. We'll be able to read them on the chat log, and we have one of our team members keeping track of those to make sure that we get those questions answered. But your input, I mean, a lot of you filled out those evaluations and really thoughtfully and gave a lot of good feedback. And we've improved our session today based on your feedback. So, and we've promised a prize, and we know, Christina Jones, that we still owe you a prize from last session. We're also going to do this spin the wheel, and we're going to give a prize to someone who filled out their evaluation after the last session. So here we go. I should have put balloons. We could have made it like a carnival if I knew that I was going to be home. So Stephanie Schutz, we'll mail you a prize, and just because I like to spin the wheel, we'll get two. Jennifer Brindle. So thank you both for creating or completing the evaluation, and the other 250 of you that did. You'll be emailed an evaluation after this session. When we close the link at about 1:15, you'll automatically go there. Please fill them out so we can continue making these trainings relevant to your needs. So, okay, so I am now going to introduce Peggy Stemler. Dr. Peggy Stemler is my boss, and she's gonna talk to us a little bit about COVID. And Peggy, we've changed this so that there were a lot of questions that we weren't able to answer during the last session about COVID-19. So she's gonna answer a lot of those questions, and go ahead and continue chatting in your questions about COVID-19, and Peggy will try to answer what she can. If not today, then in 2 weeks when we meet again. So go ahead, Peggy.
All right, gang, thanks so much. And I will also stay on the call. I can stay on today at the end if there's some more questions. Last time we did a lot of data stuff, and this time I know that has been in the news a lot, so I don't know if we have to like pound on that. This is a picture that Johns Hopkins University updates every day. So this was updated 2 days ago was when I grabbed it. It'll be the day before. And you can see Arizona is in the dark colors in a lot of Arizona, which means that we have a bunch of confirmed cases compared to other parts of the country. We are definitely, as you know, one of the hot spots in the country for COVID-19. And with that, I'm not going to talk about that too much, but you did have there were a bunch of questions about why are the numbers going up. So the things that we'll be able to talk about in the quick time today are the numbers going up due to testing? Several people had questions about just the whole going back to school thing. And then how do you help your uninsured or underinsured, the high deductible health plan clients, patients find places to get tested? So I put this up here because all of you, the title on this where it says ADHS Data Dashboard, if your handouts, if the links click, you can click those links when you pick up that handout afterwards, but just go to the ADHS website and COVID is all over it. So you'll find it easily, but this is a way that you can look at what's going on in your county, because the data is all by county, but also I'll show you in a minute, and you can even get down to zip codes. Right now, what we're seeing is that these bars in the middle of the screen, there's a big rise in the number of positive tests that are coming in, and a lot of questions about, is it this due to the testing blitz, testing being more available? And you can see that clearly testing is more available, more testing is being done. But when you look at that bottom part of the screen where it says the total positive PCR test, that's the one that you can depend on. That's like the test that you can say, if it's positive, it is COVID. Serology is a little less definitive and it's after the fact, but the PCRs are the money test. And in the testing blitz early on, the proportion of the tests that were taken that were coming back positive were like, 5, 6, 7%. And over the course of the past few weeks, the proportion that are coming back positive continues to increase. So 12, 14%, 19%. This week and the last week, those 2 gray bars at the far right-hand side, you can't really depend on those numbers yet because some of the tests take a while to get back. But we're definitely going up. More tests that are being taken are coming back positive, the percent. So we're definitely seeing community spread. And the other thing that you might have seen on the news is that you can't look at these bars on the ages and say, oh my gosh, it's all the young people, because that also depends on how many 20 to 44-year-olds there are out there. And I, of course, can now call people they're young, which is weird. But but that is an increasing proportion of the positive tests that are coming back are in that young adult demographic. So I just wanted to share this with you because on that data dashboard, this is the first page that you'll see, and you can see there's a bunch of those red circles that you can look at a lot of different data elements if you care to do so. That thing that I was just showing you was on the lab testing button, but right above that on the top right is a button where you can look at what things look like by zip code. The one thing that you won't see on that zip code map is data from tribal lands, because that data is suppressed, barring permission to publish it. So that's just a place that you can go and every day it's updated. But let's get to some practical stuff. School-age children, what's the deal with them? So I think the most important thing for everything related to COVID is we are still learning every day new information about what things look like for different groups of people, how the disease works, what are the side effects, what are the things that last. So the most important thing is what I say today might be different tomorrow. But what we know is that school-aged children can still get sick with COVID-19. They can have symptoms, but they tend to be less sick than young adults, who tend to be less sick than older adults, and all of those groups tend to be less sick than the most at risk, which are the over 65s and individuals who have chronic health conditions of any age. Kids can have, there's some rare but pretty serious complications that they can get that have to do with an inflammatory disease. And it looks kind of like, I don't know if you guys have ever seen Kawasaki syndrome. It's this, kids get rashy and they look really sick, but it's a vasculitis, a blood vessel disease. And it looks like that sometimes with COVID. Again, really rare, but kind of nasty. And the one thing that is starting to come out in studies from other countries that have had COVID a little bit longer than us and who have had some pretty aggressive data collection is that younger kids tend to be, or are more likely to be, asymptomatic or very mildly symptomatic. The young adults are a little bit more symptomatic, but it's, again, still, this evidence is still coming out. But the thing that's important with that is that this actually does have it informs why schools are thinking about doing what they're doing. So what we know from flu is that kids are flu-like spreading machines, and it seems like COVID at this point, kids may be less likely to be the COVID aggressive spreaders, unlike flu. It doesn't mean that they don't spread it, but it looks like they're not the most important way for that to be spread. And if they get it, they're a little bit safer. But everything about this is like that very big level. The most important thing for like your child, your patients thinking about schools are they or anybody in their family have a higher risk of COVID, chronic conditions, living with older people, you know, grandmas, grandpas, or whatever. So it's really thinking about what are the things that make that safe. And schools are going through that planning process right now about, just like your offices, how do you clean things? How do you make sure that hand washing is appropriate? How do you make sure people are wearing masks so not to spread if they can't be at least 6 feet apart? All those very common sense steps are happening in schools just like in your practices, and that planning is underway. It's still going to be, a lot of schools are making plans about, you know, what to do in different situations. So they're making plans as if school is going to open as normal, but they're also making plans for what if we have to do, you know, partial, you know, spread out who's in the class any given day, who's at home, and every district is making their own plan. So that's something that you'll start to hear more from your districts pretty soon. The other big question is testing for the uninsured or underinsured. This is a really hard one to answer, as I'm sure you all know, but the best answer that we can find and get to you is that there's a link to a website, again, on the ADHS website, the Department of Health Services website, that lists all the sites that are doing testing, and it has information about every site, the address, the phone number, whether or not they require pre-registration. You'll have to call to find out the cost of the test. There is a program, this federal COVID-19 claims reimbursement program, that the testing site has to enroll in. And if they're enrolled in it, they can bill the feds to pay the cost of the test. But those questions all need to be asked to each specific site. Nobody has a resource about you know, where to go if you are uninsured or underinsured. So check your area with that link to find where those tests are available. And again, I'll hang out at the end for any questions and share the information also at the end about the weekly outpatient healthcare setting webinar that Maricopa County does, that I talk, I do that webinar for them. And you guys are all welcome to join, whether or not you live in Maricopa County. It's of course, you know, a little directed that direction, but a lot of this information just goes across the board. And I forgot to click my last slide, which is, again, just this, you know, stay safe, everybody, but thank you so much for everything that you do, because again, like Rebecca and Macrina said, you guys are saving lives, and vaccines such a big part of that, and extra important right now.
Thank you. So, and like Peggy said, she's going to be able to be on the line afterwards. Sorry to scroll through all of those to answer some more questions. And we're also in the chat getting some really cool things that you all are doing to get patients back into the office. And even some people saying, you know, our well visits didn't go down, our vaccine rates aren't going down. So if you are one of the people chatting in that you're maintaining the same number of patients that you're providing care for, please also chat in why you think that is, so that we can get that message out as well. And today we're going to talk a lot about the ACIP schedule and just kind of over, you know, vaccine basics overview, but we're also going to touch a little bit on catch-up schedules and getting patients back in to the office for those of you who have, you know, have seen a decrease in volume. So keep chatting in your questions, especially about the schedule. We know that that's kind of something nitty-gritty. And we're also today going to have a demo from Megan from the VFC program about how to use reminder recall in ACIS. So we know that's something that a lot of you are already doing, and many of you have said we'd like to know how to. So let's start with key terms. Well, let's first start with, why do we immunize at all? And, you know, Vaccines are a great achievement of medicine. They have stopped diseases that used to devastate millions of families worldwide and in our country too. Before the measles vaccine in 1963, we had 3 million cases of measles annually in the US. And in 1952, there were 21,000 people that were paralyzed from polio just in that year. I mean, vaccines have truly changed our world. They prevent these diseases, they establish herd immunity, and they also prevent vulnerable people like babies and immunocompromised people and our elderly from even getting these diseases in the first place. So, key term, immunity. Immunity means protection against a disease. So we get immunity in lots of different ways. There's different types of immunity, but what it means is that you can't get that disease. So the first type of immunity that we're going to talk about is herd immunity. And we actually talked about this already 2 weeks ago. So if an adequate proportion of people in your community are immune from a disease, so they're protected from the disease, either because they were vaccinated or because they've already had that disease, the spread of that disease from person to person is very unlikely. So Macrina, tell us what passive immunity is.
Okay, so passive immunity, you can get it a lot of different ways. Probably the most common is for mother to infant. When babies are born, they have some immunity to, let's say, measles, mumps, and rubella. They have some immunity to chickenpox. We need to wait for that immunity to wane, and it usually does wane around 9, 12 months of age. But that's also why we give a Tdap to all moms in the 3rd trimester, because then babies are born with some protection to pertussis. Again, that protection doesn't last very long. It wanes, and so that's why we need to immunize. You can also get it through getting a blood donate by getting blood or through immune globulin. And again, it's usually temporary. It doesn't last that long. And then there's the other type, which is active immunity, and that's there's 2 ways to get active immunity. One is either getting the natural disease, which I think is the hardest way to build an immune response, or you can get immunizations. And routinely, those are long lasting. Sometimes a few doses will protect you for life, and sometimes you need a few more doses and boosters throughout your life. But those are the 2 types of immunity. You're muted, Rebecca. Oh my gosh, that would be so much fun if I could just mute you.
That's Peggy's dream. Yeah. I think that's a lot of people's, working remotely. My husband's in the other room on his calls, and he's like, you just chat all day long. So yeah, I think he's thrilled to hear my voice all the time. But so we have these 3 types of immunity, and we get active immunity from the vaccine or from the vaccine and getting the disease or.
And there's actually 2 types of, the most common types of vaccines are live attenuated or inactivated. And so with live attenuated vaccines, it's usually a weakened form of the wild virus or bacteria. And once you get the vaccine, it replicates in your body. So your body works itself to build those antibodies. Your immune response is similar to if you would have gotten the natural disease, but also your side effects are routinely more, your normal side effects usually are more like getting natural disease, except much, much milder. And they usually produce immunity with 1 dose.
So for this one, the live vaccines, like varicella vaccines, sometimes they'll get like a little pock, right? Is that why?
Right. Sometimes you'll get a little pock. Sometimes I think MMR is probably the most common one we see, is usually within 7 to 14 days, you might see a slight fever and a slight rash. Not contagious at all, usually goes away in 24 hours. But those are usually the reactions, the normal reactions you see with live vaccines. Now with inactivated vaccines, they don't replicate in the body. They do a different immune response. They're unaffected by anything that's circulating in your blood. So they're unaffected by any mild illness, any blood transfusion, any medications you're taking. They usually require more doses, 3 to 5 doses, usually a primary series with boosters throughout life. Your antibody titers will diminish over time, so you really can't measure to see whether you're immune or not very well with inactivated vaccines. And with those, most of the normal adverse events are usually local without fever. There's nothing systemic. It's usually just a sore arm and goes away a couple days.
So Ralph is asking in the chat box, if someone's immune to a disease, can they still transmit the disease?
Well, if someone's immune to the disease, they can't get sick with the disease, therefore they can't transmit it.
Okay.
You've got to actively be sick to transmit disease.
Okay. Okay, so we've covered immunity. We have our 2 types of vaccine. We've talked about what is immunity, the types of immunity, the types of vaccines, and those are the most common vaccines that you're delivering. You know, we're hearing a lot about COVID-19 vaccine, and we even have some questions about that in the chat box. So maybe at one of our future things, we can talk a little bit more about that. They're using the same old technology for this vaccine. We just read, Macrina and I were emailing back and forth that article, Macrina, from USA Today.
Oh, it was incredible. And the good news with that one is it has pictures. So for all of us who are not chemists or pharmacology folks who make vaccines, it was really helpful. They're using all sorts of new technology, and these vaccines are being made in several different ways. If you're a vaccine nerd or geek like Rebecca and I, this article will totally be fascinating.
Yeah, we'll send that out with the other materials after this session, just for us vaccine nerds. But so let's go ahead and I do think that we should probably, Christine Dixon is chatting in on here. Remember, vaccines aren't 100% effective. True, right?
True.
Yes.
Correct.
I think that's a good thing to make sure that we point out too. So why don't you tell us about some vaccine, what are our basic general rules?
Well, the first one is the more similar the vaccine is to the organism that causes the disease, routinely the better the immune response. That's why live attenuated vaccines work so well. You usually get an immune response that will last a lifetime without needing boosters. The next, oh, we got a quiz.
We have a quiz. So, Chris, could you launch the poll that's called Many? We know that a lot of you, this is truly a pop quiz. So how many vaccines can be given at a single time? So you're going to want to, when you answer this, you'll click on the correct answer, and then you can close the poll. And as soon as Chris sees that the answers are starting to dwindle down, then we'll go ahead and share the results. There are no limits, 50%. That's your rule, right?
That is my rule. Yay!
Yeah. So there are no limits for how many vaccines that can be given in a single visit. And when I travel a lot to clinics, and especially our health departments, and you see some, especially those refugee kids, coming out of clinic with just Band-Aids all over the place. But what do you say to parents about that when you know that that child is going to get a lot of vaccines? What do you say?
I think that's probably that's the hardest part of anybody who administers vaccines, is being able to make a parent feel comfortable about giving all the vaccines that they need at a single visit, especially when we're going to be seeing a lot of these kiddos that are going to be coming back between 18 months and 24 months and are going to need everything. That could be up to 5 or 6 injections at a time, and it's perfectly safe to do that. But sometimes it's a little scary for the parent. I think it's more scary for the parent than it is anybody else. So you just need to make it feel comfortable. It's safe to administer them all at the same time. And the longer that these kiddos remain unprotected from these vaccine preventable disease, they're actually at more risk than they are by giving several vaccines at one time. And that's going to be the hardest part of our jobs, all of us who give vaccines, is trying to make parents feel comfortable with doing that.
So what's your next general rule here?
Next general rule, which is sometimes a little confusing, is that increasing the interval between doses of a multi-dose vaccine doesn't diminish the effectiveness at all. So I know we have a lot of parents come in and say, you know, it's been 3 years since they had their first HPV. Don't we need to restart? And we don't. That first vaccine did the work it needs to do, so we're going to give the second one, and the kiddos are going to be protected. But decreasing the interval between doses of a multi-dose vaccine can interfere with the way the body responds. So you really need to pay attention to those minimal intervals, because giving them too close together, then the vaccine just doesn't build the immune response the way it was meant to. It actually will decrease its protection. So that's why that's really important not to give them too close together.
And I know that next month we're going to talk more, or in 2 weeks, our next training, we're going to talk more about contraindications and precautions. But what are just remember these things?
Well, there are 3 permanent contraindications. It's a severe allergic reaction to a vaccine component, and we mean severe allergic reaction. I know that we ask some questions and it's not, you know, they get an upset stomach, but it's severe. They need to seek medical attention. With any of the pertussis containing vaccines, is encephalopathy without any known cause, 7 days prior to a dose, 7 days after a dose, and then a combined immunodeficiency disorder, and that's routinely rotavirus. There are 2 temporary contraindications to live vaccines, and this is live vaccines only, and that's pregnancy and immunosuppression. And so routinely with pregnancy, once mom has a baby, we can go forward and immunize with those live vaccines. And with immunosuppression, those are routinely our kiddos or adults who are getting cancer treatment, transplants, some medication routinely. And then you just need to make sure that there's a safe time span between that before you immunize.
Okay. So, and again, we'll talk more about that in 2 weeks when we talk about screening for your patients. So, but we thought we can't talk about vaccine basics without reminding you that there are contraindications that you need to make sure that you remember about. Okay, so we've talked about types of immunity, types of vaccines, a little bit about how vaccines are made, you know, how they are, you know, when we talked about the types of vaccines, and just general rules about why we give vaccines, when we do. And all of this goes into the schedule. So the CDC's Advisory Committee on Immunization Practices, ACIP, is the body that designs our schedule. So this is a panel of 15 experts. They meet 4 times a year. They're actually meeting today. And Arizona has actually made an appearance on ACIP. We've had some of our docs from here in our state that have served on ACIP. And they are the ones who developed the written recommendations and established our schedule. And boy, do they make schedules. This is our pediatric schedules are there on the left. There's 2, you know, that main ones, the 0 to, well, I think actually they have a baby one, a teen one, a tween one. It does seem to get bigger as we invent more vaccines to protect from more diseases. They also have the catch-up schedule. If you only do pediatrics and you are already thinking to yourself, man, it's hard to reference that schedule, be happy you don't do adults, because that one is even more complicated. I think it's more complicated than the pediatric one.
It's more complicated.
Yeah, because it's age and then also conditions too. So
yep.
Either way, you need to be familiar with the schedule for your patient population, and just know how to reference it.
Yeah, because there's absolutely no way you can memorize all of this.
In the old days, you could. Huh?
Oh yeah, in the old days you could. Like when the year, like, yes. So we have them here from 1960, 63, and 1983, the year that Rebecca was born. And kind of the 1963, around the time I was born. And they were pretty simple. So anyone could really memorize them. You didn't have to have, you know, a notebook with 5 or 6 different schedules and then 12 pages of footnotes. So I've been doing immunizations for a really long time, and I have staff and that's all they do 100% of their time. And they still need to have these resources close at hand to help them make sure they follow the schedule.
And we know that a lot of patients, especially, you know, when we're thinking about kids, and go ahead and chat in any questions that you have specific to the pediatric schedule. If we don't answer them now, we will, you know, from 1 to 1:15. But we know that they're asked for alternative, patients and parents ask to use alternative schedules that they've found online or in books. And Chris, can you launch the poll called Alternate? We thought it might be interested for you all to hear from one another. How often are your colleagues asked to use alternate schedules? So is this something you hear from your patients every day? Is it, you know, not every day, but definitely a few times a week, maybe a little more rare, just a few times a month? Or is it kind of once in a blue moon? You've been asked a few times, but not a lot. Go ahead and you should see a poll popped up on your screen. For those of you who are using multiple screens, sometimes you can't see the poll pop up, but go ahead and answer that. And we know, Macrina, a lot, we've heard at TIPS before, a lot of folks don't, you know, many clinics don't accept patients anymore that don't follow the ACIP schedule.
Right, if they don't follow the standard schedule, or if they come in with something written off a notebook or something pulled offline.
Yeah. Oh, this is
wow.
Yeah.
This is great.
Yeah. That's fabulous that people are asked about this kind of once in a blue moon. And I think that this is probably more common in pediatrics than in adults too. So, but some of you are still experiencing that every day.
Yeah, and usually how I answer that question is when we have folks ask, most of the alternative schedules have never been studied. There's been no research. And I always pop up and say, I am 56 years old, and I found my immunization record a couple of years back, and I got DTP at 2, 4, and 6 months, and then my booster dose at 15 months. So I feel pretty confident that they have studied that schedule for quite a long time. And sometimes just telling people how old I am, they kind of, you know, they feel like, oh, she must be telling the truth because she's giving her age.
Yeah. You know, one of the questions that someone chatted in at the last training was, do schools require 1 Hep A dose or 2?
Schools don't require Hep A at all. Hepatitis A vaccine is not required anywhere in the state of Arizona. And it's only required to attend preschool, childcare, Head Start, early childhood programs in Maricopa County. And sometimes that's a hard question to answer because required sounds so strong and recommended sounds a little wishy-washy. And usually we just talk about for good health and to be protected against diseases, all these vaccines are required. But it doesn't, vaccines to be required for school and childcare, it's a legislative process. It takes a lot of work. And sometimes if we just provide education to our families and parents about how important vaccines are, then whether or not they're required or not, just kind of remove that from the conversation altogether. Because you're the pediatrics office, you're the person who's giving them that medical advice. And the medical advice are these vaccines are recommended.
Yeah, I think one of the coolest things that we've heard from TIPS, you know, we always ask people at the end of a TIPS training, what's something that you're going to change? And my favorite thing to read is stop talking about required vaccines, because really as medical professionals, your job is to talk about medical guidelines, and what ACIP recommends is the schedule, and it's not going to match up with the school requirements. So making sure that you can clearly communicate to your families, this is what's best for your child. You know, we're in charge of health, they're in charge of education, and doing that in partnership with schools, which really are key partners in keeping our rates, our rate, you know, the school requirements are really important in keeping our rates high up. So, you know, we talked a little bit about catch up. There is so much in the chat about how you all are getting folks in your offices. I think probably after this, we will make sure to get all of those good ideas and send them back in the thank you email that we send. I think the biggest thing, which Macrina touched on earlier for this, is we're going to have, many of you are going to have to be doing a lot of catch up and ensuring families that it's okay to provide, you can give as all the vaccines in one visit. There are no vaccines that you can't give together. What's important is that there's space, that the intervals are correct, and making sure that those families know what to expect for the next visit. So
I think
today you're getting not next time.
Yeah, I think that's the most important thing, is on that first visit when they're sometimes really delayed and they get a lot of vaccines at once, and you can just look the fear in the parent's face and they're like, oh, I'm not going to come back. But just spell it out, even on just a sticky note that says, you know, okay, so we got 5 today, but he's going to come back in a month and only get 1. And then you could kind of see the parent relax, and then, you know, kind of spell it out. And in 6 months, he's all going to be all caught up and he's good to go. And that sort of keeps them on track, and there's less fear in coming into the next visit.
Right.
Yeah, you just need to, and the minimum intervals and minimum ages are pretty important, because there's a minimum age for receiving the initial doses. Can't give them earlier than 6 weeks. There's minimum intervals between doses. We do have a 4-day grace period, and it is a 4-day grace period that has to do with both age and the interval. And it is 4 days. It's not 5 days. It's not 6 days. It's 4 days. And I know that sometimes gets to be a little bit of a discussion between parents and nurses and MAs. If a dose of vaccine is given too short, then you need to repeat it.
Okay. So if you give the vaccine before the minimum amount of days, then you have to repeat the vaccine. And that happens even in our measles outbreaks when we immunize, right. You know, when the county health department says start immunizing those babies earlier, you can do that, but they still have to get it again at 12 months.
They have to get it again, correct.
So let's talk a little bit about the adult schedule before we get our reminder recall. This adult schedule.
Oh, the adult schedule. So the adult schedule, they actually put it in a way that it's a little bit easier to use now. So most adult vaccines are recommended based on some sort of chronic medical condition or medical condition. So this schedule is really good, because you can just go along the top and find out, so what medical condition do we have here? And then just go down the list and find out what vaccines are recommended and should be given. This is much easier to use than trying to go through that pink book and find out what somebody with diabetes needs. And then we also have it broken down by age. There are some vaccines that are recommended for 65 plus, 50 to 64, and then that younger age population. And so then you can kind of use both of those. It's much easier to figure out what an adult needs with these schedules.
All right, so why don't we do have a lot of resources on our TAPI website, and we will email a lot of these out to you too. We have a calendar that helps you see those minimum intervals. We have reminder recall postcards, but let's move now to Megan from the VFC program. And Megan, why don't you share your screen and walk us through how to do reminder recall on ACIS? And I think, Megan, you can share, and if you want to share your camera, that'd be great too, so we can see your face, or your dog, depending on whose face is at the computer.
I locked her out because she'll try to bark.
And so reminder recall, I think you're going to show us some for the pediatric schedule, but they can do this for adult vaccines too, as long as their data is accurate in ACIS, right?
Correct.
All right, take it away.
All right. So this report, these report instructions are online. They are under our homepage under the assessment AFIX header. We are going to be updating them because we have, of course, had changes with ACIP. So these will be available for you. As Rebecca said, the Probably the most important thing to remember with reminder recall reports is that the data that you put in ACIS is going to make a big difference with your reminder recall reports. So it's important to make sure your data is up to date, especially with historical vaccines. We just want to make sure that you're getting those in there if you have that information, so your reminder recall reports will be accurate. So on the reminder recall page in ACIS, on the left-hand side menu, you just select reminder recall. That will create a drop-down, and then you would just click on reminder recall. It'll bring up this page here on the right. We will go through these pages, but this is what it will look like. How do you want to run this reminder recall? It's going to default to for all patients you own, and then you can select the due date time frame. So you can select due now, your 3 months or past month due, 2 month or past month due, so forth and so on. So really, however you want to set this report up, that will be easiest for your practice. A tip: under the due date time frame, you decide what selections will best fit your needs for the report you are trying to create. For instance, you can select due now, or maybe you want to only select patients that are coming due in the next 2 months. So again, however you would like to set this report up, that will be helpful for your practice. On this page here on who do you want to contact, you're going to select the name or clinic site and facility, and then you'll select either the patient age range or the patient birth date, run it one way or the other, and then the patient age range, for example, 24 months to 35 months or 13 to 13. We say 13 to 13 because ACIP only assesses at 13 years, but you can or may want to expand your focus if you're looking at other timeframes that are necessary for your practice. And then you would select your patient date of birth. One of our tips is focus on one age group at a time, selecting patients at age 11 and recalling Tdap, MCV, HPV, or selecting patients at 4 years of age for their kindergarten shots. The choice is yours, as there are a lot of possibilities. Which vaccines would you like to include? You'd select the series for your report, for example, the 431, 3314, the Toddler series, or you could select the one Tdap, one MCV, and the up-to-date HPV. With the HPV, you may see 3 listed as the number of doses. However, that will include patients who are up to date with the 2-dose series. Then you would select due for all selected vaccines, and then you would just push generate patient list. A tip would be deciding which antigens you would like to select for your report. For instance, if there was a measles outbreak, you can custom select MMR to see which patients have received their MMR vaccines. So again, you're not limited just to the Toddler series or the Adolescent. You can open it up to whatever best suits your practice. Creating a customized report, you can select custom, check the box to select the vaccines that you would like to run this report for. Then you would enter the dose number for select vaccines, whatever dose number you're looking for. Then you would select due for all selected vaccines on the bottom there, those 3 check boxes. And then you would press generate patient list, and that will create your patient list. Oh, there we go, got stuck. So meningococcal B recall report and patient record. Meningococcal B vaccine should be made using a shared clinical decision making. So this means that providers and their patients should decide together whether or not this vaccine is right for the patient. So therefore, patients will only appear on the recall list if they have received the first dose, but not the second. Patients who have not received any doses of meningococcal B will not be on the recall list. Meningococcal B is different from the quadrivalent ACWY vaccine. So please just make sure you understand that distinction, and that Men B will only show up if the patient has received their first dose, but not the second. What patients do you want to add to your recall group? You can remove patients if needed. In that first box there, if they don't have a name, phone number, address, email selected or listed, you'd be able to remove them. Then you would select patient demographics, patient address, phone number, cell phone, or email information in ACIS, and then inactivate multiple patients that are no longer at your clinic or practice. We only recommend this if you know for a fact that they don't come to your practice anymore, if they moved out of state, if you know they're being seen at another practice, those would be the times when we recommend inactivating patients. Then you would be able to export this to Excel, or you could press submit to create the report. There are only 2 selections to choose for inactivation. Only inactivate patients if they have moved or no longer receiving services at your practice or clinic, as I mentioned, is our tip on that.
Megan, we have a question asking, who owns the patient? Is it the last provider that administered a vaccine, right? But not if it was at a county?
Correct. Counties don't take ownership, so whoever the last practice was to vaccinate them is the owner.
Okay, thanks.
All right, so what do you want to do with your selected recall group? The numbered icons across the top indicate how many people are in your recall group. So the little icon with the man in the green indicates how many you have in your recall group. The house represents that they have an address. The phone represents that they have any phone number. The cell phone represents they have a cell phone number. And then of course the email, they have an email address listed. And then you would just select generate a patient list to create your recall report. Generating a patient list, instruction window message will appear, and then you'll just click on run to generate your patient recall list. Please keep in mind, by selecting specific criteria, you are able to control the number of recall attempts on a patient. You can select different age ranges and antigens of patients you want recalled. Then your toddler reminder recall report will look like this. In the green is the vaccine series that was selected. In the orange is the number of patients that were in the recall group. In the blue is the patient demographics. So of course their patient ID and ACIS, first name, last name, birth date. And then in the red is their missing vaccines, what dose they're missing, recommended and minimum dates recommended and minimum dates vaccines are due in ACIS. So this will give you the recommended date they should have gotten that dose, and then the minimum date as well. And again, this is why I say making sure that ACIS is up to date directly is key for this report, because if you just update your EMR, ACIS won't know. With historicals and such, if you're only updating their EMR, ACIS won't know unless you send those to ACIS. This is the adolescent reminder recall report. Again, the green is the vaccine series. The orange is the number of patients in the recall group. The dark blue is the patient demographics. The red is any missing vaccines, the dose that they're missing, recommended and minimum dates per ACIS. And then in the light blue, the recall report also includes MCV number 2 and Tdap number B for the booster. So you can also look at that information if you need it for your adolescents. And you can put any questions you have in the chat box. You can call our office if you need to speak to somebody. You can reach out to your immunization program specialist by calling the main office, or you can contact them directly. And I can answer any questions you have in the chat box.
Thank you. And you can post these slides, mail these slides out too. Yeah. To be able to help you. Great. I know that we've been asking folks, what are you doing to bring patients back in? And they're saying that they're using the reminder recall. So Marissa Werner we'll send Marissa Werner a prize since she chatted that at the last session that they're using the reminder recall. So if you want to unshare your screen, Megan, and we'll go back. Thanks for doing that.
Of course.
So we have a couple. Macrina, what would you say are we're wrapping up here, and remember we're going to keep our line open for 15 minutes, and I've been jotting down some questions that we haven't gotten to answer yet. But biggest tips and tricks for vaccine basics and the schedule.
Yeah, always have a calendar in the room. It's hard to count backwards or forwards. So it's much easier to have a calendar in your exam room. Count the weeks between the shots, not necessarily just jump from month to month. Check the age of the child to assure that they are the age they are. A lot of parents will say their kiddo is 1 year old, but they're only 11 and a half months old. And so that you really want to make sure that first MMR and varicella are 12 months of age and older. And use a flow chart to help with some of the vaccines. I know there is some confusion with adults and pneumococcal, PCV13 and pneumococcal vaccine. And I know ADHS has some flow charts on their webpage that Dr. Lewis has created to help make that decision making a little bit easier. Yeah. So use whatever tool you can find from a reputable source, CDC, ADHS, your local county health department, that can make it easier for you.
And we'll make sure to send out what we have both about getting patients in with reminder recall, and then we have that great pneumococcal flow chart that Dr. Lewis created for our adult patients, which is really cool. So our next session is Wednesday, July 8th. We're going to talk about protecting the cold chain and preparing for patients. We're also going to try to talk about preparing for flu season. We really need to all immunize as many people as possible for flu this year. And also, there were a couple questions people are chatting in that they didn't get the resources after the last session. We did email that out on Monday. So if you did not get it, please email us so that we can make sure you do get the resources that were sent and kind of troubleshoot why hopefully we're not bouncing back from your firewalls. So if you have to go, Laura Smith, if you could chat in, if you haven't already, the link to the survey, to the evaluation. If you do have to go at 1, we're going to chat that in now. It will be emailed again on Friday. For those of you that have to leave, thank you for all you do. Have a good 4th of July. And thank you for bearing with us as we've had to adapt quite a bit today and our presentation due to some things out of our control too. So thank you very much. And we're going to start our Q&A. And I have some vaccine ones first, Macrina, and then maybe we'll COVID ones. Peggy, I'm not sure. Maybe you can scroll back and the chat. But let's spend a couple minutes on the vaccine one. So if you miss a window, so Twilla's asking, if you miss a window, can you do that vaccine later?
Yes, because if they're due to come back at 4 weeks or 8 weeks and they don't come back till 12 weeks, you're just going to go along with the schedule and go ahead and give that vaccine.
Okay.
I hope that's the question.
Yeah, I think so. Chat in if you think that it wasn't the answer, Twilla.
Yes, please chat in if I didn't answer your question.
Yep, she says, okay, great, thank you.
Okay.
Yeah. And is that for all vaccines?
Oh, well, no. Good job, Rhonda. Rotavirus is a vaccine that you can age out of. And you also can age out of Hib and pneumococcal vaccine, but that's at the upper end, the 4 and 5 years of age. But rotavirus is the one you really need to count weeks and months.
Okay. Can DTaP and PCV13 go in the same arm? That's from Denise.
We don't give them in the same arm because those two can be a little bit more reactogenic. So we normally give the DTaP in the left vastus, and then we give the PCV13 in the right, just because they can be a little more reactogenic, and so we separate them.
So you don't have to, but it's a good idea.
You don't have to, but it's a good idea.
You don't have to, it's just a good idea. That's good. So we had a question from Dee Begay about HPV, MCV4, and MenB for breastfeeding moms. So can they get those?
I believe yes, if they're breastfeeding. Yeah, because they're inactivated vaccines. You can even give the live vaccines if they're breastfeeding. The routine vaccines, but yeah, if they're breastfeeding, you can give them.
Okay, and speaking of HPV, you can give that up to 45 now. So that's a question that people have been chatting into. You can.
Yes, you can. You can. Mm-hmm.
If your practice is not already giving HPV to patients up to 45, ask your practice manager why not, because it might be a billing issue, or it might be because they didn't know that CDC did publish that in MMWR last year. So, but right. We're preventing cancer. Is there a specific way to give HPV, MCV, and Tdap at 11, like which arms and?
Okay, so we recommend that the Tdap and the Tdap goes in the left, the meningococcal and HPV go in the right. There's really no hard, fast rules. That's just what we do. A lot of people wait and give the HPV last because it is a little more sting and it does hurt a little bit more, and you can really see those adolescents who are straight-faced get a little bit more their facial expressions. Routinely, I give the HPV first because if it's a scary adolescent, I give it a scared adolescent, I give it first, and then I say, okay, now that's done, the worst one's over, and then we give the other two. So I think it just all depends on your technique, and you know, with adolescents, you have to be a little bit more, you just have to really kind of talk them into it and keep working them through it.
Yeah. So
it just depends on what technique you use and whatever works best for you. What do you have the most success with?
And we will talk a lot about vaccine, not at this next session on the 8th, but the one after that, we'll talk a lot about vaccine administration. So Macrina can share what she does and what goes in which arms, but you can provide all of them. Clinically, you can put them
yes.
in this. Clinically, you can do that. Clinically, breastfeeding mothers can get all vaccines. And thanks, Catherine Cohen, who's an IBCLC, who's chatting that in and wants us to make sure that we know. So Amber Bennett has a question. I have seen a child miss their 2-month vaccines and then come back into clinic for 4-month well-child check. They were no longer due for rotavirus at 4 months. Does that mean they no longer get that vaccine for the rest of their life?
Correct. If they're too old to start, they don't get it for the rest of their life. But with rotavirus, most of the children who are at risk are those really younger kids. They're more at risk for dehydration, hospitalization. So that's why we give it at the younger age.
Okay.
Yeah.
So Ashley had asked earlier if they had someone come in who had an injury at work. They had Tdap in the last 10 years, but do they need another Tdap?
So how long's it? So if it's, this can get complicated, but if it's been less than 10 years, then they're good. If it's been 10 years or longer since they've had their last Tdap, the ACIP just changed the recommendation, so you would need to give another Tdap or TD, but if you don't have TD, go ahead and give Tdap.
Okay, so speaking of Tdap, I had my Tdap at my last pregnancy. Do I really need one for this one too?
You need one with every single pregnancy in the 3rd trimester, every single one. And that's because when you give that Tdap in the 3rd trimester, that baby is actually born with some antibodies, that passive immunity, so that baby is protected. That's why the mom needs it in the 3rd trimester of every pregnancy. And I think that that's something that sometimes gets missed, is the reason why.
Yes. All right. Does Hep A have a 4-day grace period?
Yes.
And Jennifer did chat in. There were some questions about the 4-day grace period. So I think she chatted in the link to that with CDC. So everyone likes to play one. And then Janine, and I think Janine's working in a shelter.
Okay.
I think somebody's working in a shelter, but she's saying these catch-up schedules are really tough. What are your best practices, like for catch-up schedules?
They are really tough. I guess
feel better.
Because each one is so different. I mean, it's not like everybody's on the same catch-up schedule, right? If everyone could come at the same delay rate, that would be perfect, but they're all different. And then sometimes they get complicated because, you know, you can give a polio now, but you have to wait this time. I just look at it. I give them everything they need on that first day. And then I write it out, that schedule, for the parent to let them know, no, this is what they're going to follow up on. And so they kind of see the light at the end of the tunnel. When are they going to be complete? And they recognize that in a lot of cases with those kids that are really delayed, like maybe some of those adolescents or those 6-7-year-olds, that they're getting as many as they're going to get at one time today. And this is when they're going to come back and continue to get vaccines. But that's what makes the catch-up schedule difficult. And it's even worse if you have families of 5 or 6 or 7 children, and they're all on a different catch-up schedule. I feel your pain.
Well, and Janine, you're probably, if you're working in a shelter every day doing that work, you are probably the expert in the catch-up schedule. So whatever.
You definitely are.
So whatever resources you're using, or tricks you have, we'd love to hear them. So that's really important work. So it looks like a lot of these other questions are about administration, and we will make sure that we get to those in a few weeks, but I want to make sure that we get to those COVID questions too, just during the last 5 minutes or so. So Peggy, what other COVID questions did they have?
So there are a few questions around repeat testing, like people who get tested more than once. So I'm trying to tease that apart. So the first question, as I read it, is if you have one person who keeps getting tested, whether or not they're negative or positive, what does that do for the counts? And the answer to that is every person is counted once. So once they're positive once, they've already been counted forever. And they can keep getting tested if they want to, but they only count once. So that's not what's building the numbers up. Some people may do that just to kind of, because they're negative, but they're not convinced, or whatever reason. Some people just want to make sure and they're scared, but you only are counted once. The other thing, though, that's really important is that we do not recommend testing for clearance, because what we do know is that you can still test positive, like the virus that you swab out, that material that you get out can still test positive even if the virus doesn't actually grow in culture anymore. So it's not going to be contagious anymore, but you can still test positive. And every time you test positive, you're quarantined for another 14 days. So, you're quarantined for your 72 hours after you've had your very last symptom that could be anything related to COVID-19. So just don't test for clearance. It's not useful. We had another question about if somebody's already tested positive, if they had COVID, can they get it again? Are they immune? And I think the answer to that is in the short term. So this is brand new. Okay, I want to say first, this is brand new. So gosh, we don't really know for sure yet, unfortunately. It does look like COVID will, at the very least, behave like other coronaviruses and the same sort of family, and that you will have some sort of immunity, but we don't know yet for sure. The bet right now is that it'll behave sort of like flu, where there may be some changes each year in how it looks to your body. So you can still get it, but it may or may not be as severe the next time, just depending on, it's just like flu, how bad the flu is that year, that virus, that year, the strain. There is a question about who gets those PCR tests, the diagnostic tests. And right now, anybody can get that test that goes in, anybody can go in and ask for it. When you say anybody can get it, you have to be able to find a place to get tested. The place has to have the equipment. There may be a cost associated with it. Ask the price up front. You have seen, I'm sure, horror stories in the news about people getting massive bills for the test, but it is not restricted anymore only to people with certain symptoms. And then a big one, I think, for offices is what happens when you're at work and somebody on your team has COVID, test positive. What does everybody else do? So the answer, and this comes up a lot on our healthcare webinar also, and the answer to that is, first of all, when you're working in the office, seeing patients, you need to be wearing a surgical grade, like that medical mask, not a cloth face covering if you're doing direct patient care. So if everybody in the office is masked and somebody tests positive because maybe they got infected at home or something, then you have a level of confidence that you're protected because you're both wearing those higher quality masks that are more protective about catching COVID. But the second thing is that because healthcare providers are essential personnel, so in this one particular office, everybody else on the staff got tested as well. You can still work if you've been exposed to COVID. You got to wear that mask, that surgical mask. And if you have any symptoms at all, and it's not just fever, remember it's, fever or muscle aches or just feeling bad or sniffles or cough, you can't smell or taste anything anymore. That's a unique COVID symptom. You're sick to your stomach, anything, stay home, because that's when you're no longer essential. It's essential that you stay home if you have any symptoms. So, and somebody said the news just announced that yes, you can get it again. No surprise. So hopefully not this year, but hopefully it's more like flu where it'll be next year that you can get it again. But yeah, you just have to be careful.
Yeah, and that data, Peggy, that data, like she said in the beginning, this is brand new. I mean, there is no expert on this because it's brand new. I mean, the experts are all kind of still learning too. So everything that we learn today might be proven wrong tomorrow. I mean, it's just so new.
Yeah. Yeah.
So it's 1:15. The question and answer, I think this was really great. So if you think that it was helpful to stay on for 15 minutes, let us know. But you kept staying on, so we'll assume that this was helpful. Thank you all so much for what you do. Please take the evaluation and let us know your thoughts so that we can continue to improve our tips training sessions. And have a safe 4th of July. This may be the closest we get to a cookout or fireworks. So, but thank you all so much. Bye-bye.